So let me just record this part. Okay, so we are looking at Addison's disease. Okay, and for Addison's disease, we say it's the adrenal hypofunction, so loss of function of the adrenal gland. Okay, usually we lose its glucocorticoid function as well as its mineralocorticoid function. Okay, and the causes are infections. Okay, infections. And in our part of this world, we have tuberculosis being one of the commonest cause of Addison's disease. Okay, and we can also have meningococcus. Okay, and we also have autoimmune destruction of the adrenal cells. And we have secondary depositions. So we have some infiltrative lesions, amyloidosis, sarcoidosis of the adrenal, as well as heavy metal poison like hemochromatosis, where you have iron infiltrating the what's the name? The adrenal gland. Okay, good. So these are some of the causes, and the effect is as a result of the reduced glucocorticoid action and the reduced mineralocorticoid action. Okay, good. Now we said one important function of the glucocorticoid hormones, okay, is that they cause increase in blood sugar level in periods of stress. So with these people, they are more likely to suffer from hypoglycemia. Good. Once again, we saw that glucocorticoid also can lead to increased hypertension, increased blood pressure. These people with Addison's disease, hypertension, okay? So it's just like the opposite of Cushing's disease. Also, because of the reduced mineralocorticoid function, we know that the aldosterone is responsible for reabsorption of sodium. So in this case, sodium is not going to be reabsorbed because there is low levels of aldosterone. So in this case, there is going to be hyponatremia, okay? And because there is not going to be reabsorption of sodium, there is not going to be secretion of potassium and then H plus ion. So the metabolic picture of this person is hypoglycemia. Okay, I can add hypotension. I can add hyponatremia. Okay, then I'll add hyperkalemia and then metabolic acidosis. If you understand the functions of cortisol and aldosterone, you can easily talk about the conditions, okay? Good. So the causes. So we've seen the primary causes. So this cause is actually as a result of problems with the adrenal gland itself. But remember that you could also have problems with the pituitary gland. And if the pituitary gland is affected, know that your ACTH production is going to be reduced, and hence you cannot produce the adrenal hormones. So infections of the pituitary gland, ischemia of the pituitary gland, and remember we mentioned Sheehan's syndrome, if you remember, which is from postpartum hemorrhage leading to shock, okay? And that reduces blood supply to the pituitary gland, and then it undergoes ischemia and then necrosis, okay? Good. Remember surgery. If someone has a pituitary gland tumor and you go and remove the pituitary gland, the question is what's going to produce ACTH? So we are more likely to develop adrenal insufficiency. Good. Clinical features. Clinical features is like someone who is hungry, someone with hypoglycemia, because in fact they are hypoglycemic. So tiredness, weakness, lethargy, anorexia, vomiting, okay, weight loss, dizziness, pigmentation. Now pigmentation over here is because of increased ACTH production. Now remember that if they are not producing the adrenal cortical hormones, okay, now the hypothalamus will say that no, this person is not producing cortisol and aldosterone. So what's going to do is that it's going to increase CRH hormone. Then the increased CRH hormone is going to cause the pituitary gland to produce a lot of ACTH. And this ACTH, remember, can cause pigmentation. Okay. There are some other causes which I'll leave you guys to, to read. Okay, we've talked about most of them. Okay, there's a condition we call adrenal crisis, which these people suffer. Okay, so it's an acute condition. Okay, it's a very dramatic condition which you must know how to deal with carefully, or the patient will die. So this is a case where their blood sugar is low, they have hypertension, their blood pressure too has gone very low. Okay, they are entering into shock. Okay, good. So the features are fever, dehydration, okay, nausea, vomit, and hypotension, hypokalemia, as well as the electrolytes abnormalities. Remember I said hypotension, hyponatremia, hyperkalemia, metabolic acidosis. Okay, remember this. Good. So how do we diagnose? So what we do is that we measure the ACTH levels, okay, and then the cortisol levels. Okay. So first of all, we expect that because the person is not producing, and this we are talking about mainly the primary diseases affecting the adrenal gland. Okay. So now the adrenal gland the adrenal glands cannot produce the cortisols, okay, cortisol and the aldosterone. So there's going to be increased ACTH level. So for the measurements for the primary causes, remember that the cortisol levels are reduced, ACTH levels are increased. Okay, good. So then what do we do? We perform what's called the ACTH stimulation test. Okay, so we want to know whether really this person has this disease. So what you do is that you inject the person with a synthetic ACTH, and that ACTH should, in a normal person, will cause the adrenal glands to produce cortisol. So the synthetic ACTH is what is called a synaptin. Okay, the name means synthetic, the syn means synthetic, ACTH in. Okay, so synaptin, so it's a synthetic ACTH. So you inject it into the person's blood, and then you take the levels, okay, the levels of cortisol production. Okay, if the cortisol production is still low, then obviously the adrenals are destroyed, the adrenals are not working. Okay, but if after giving the ACTH the synthetic ACTH and the adrenal glands produce cortisol, then you're like, okay, the adrenal gland has still retained its function. Okay, so this was what's happened. The same thing, I've explained everything. Okay, you give the synaptin and you measure the levels of cortisol. If the cortisol levels are reduced, then Charlie, we've lost the adrenals. Good. Conn's disease. So Conn's disease is also a hyperfunction, okay? And in this case, you are producing high levels of aldosterone. High levels of aldosterone. So it's called the hyperaldosteronism, okay? Remember, I didn't say Conn's disease. I said Conn's syndrome. So this one is just like Cushing's, okay? So this one is just excessive aldosterone levels. And what can cause excessive aldosterone levels? One, when you have tumors of the adrenal glands which are producing aldosterone. Okay, good. Two, someone who how do you call it, has a genetic condition where they are just producing a lot of aldosterone. Okay, so they don't have any tumors or anything, but they are just producing a lot of aldosterone. We know what aldosterone is going to do: increase blood pressure, increase blood pressure. Okay, so reabsorption of sodium and water, excretion of potassium, and then leading to hypernatremia, okay, hypokalemia, and metabolic alkalosis. Okay, and then they also have muscle weakness because of the hypokalemia. Okay, so remember I said potassium affects organs that require electrical activities, okay, like muscles and nerves. Good. So all these things have been explained. Investigation. So what you do is that if you have someone who has hypertension, okay, someone has hypertension. We know in Ghana here, the commonest cause of hypertension, the primary hypertension is the commonest, okay? But in some few people, we could have secondary hypertension where there's a defined pathological cause, okay? So if you get someone with hypertension and they have hypokalemia, okay, and inappropriate calories, okay, that means that the patient's urine contains a lot of potassium. Then that one you should be suspecting Conn syndrome, okay? As I said, there's metabolic alkalosis, and there's also impaired glucose tolerance, showing that this person has aldosterone, high levels of aldosterone with some glucocorticoid effect, okay? So the diagnosis, so what you do is that, remember this, remember the renin-angiotensin aldosterone system, okay? If your renin levels are high, in a normal patient, it's the renin that causes production of aldosterone. So renin will cause the angiotensinogen to be converted to angiotensin 1. Then angiotensin 1 will be converted to angiotensin 2. Then angiotensin 2 will stimulate the aldosterone synthase to produce aldosterone. Okay, good. So yes, so that's the normal way, okay? But someone with Crohn's disease who is producing high levels of aldosterone, okay, the aldosterone is going to inhibit renin production. So this is a case where you see a patient with high aldosterone levels and low renin levels. Then you should be suspecting Crohn's, because if I have high renin levels and high aldosterone level, then that one makes sense, because renin is going to lead to production of aldosterone. Okay, but if I have high aldosterone levels and low renin level, then that means that something else is producing the aldosterone, and that could be a tumor. And that increased aldosterone levels is inhibiting the renin production. Okay, so there are some questions here. Let's see. So someone is saying both Conn's and Cushing's syndrome produce similar symptoms. What criteria should be used for tests? Or do you let... No. Okay, they don't... You see, for Conn's, the effect is due to increased aldosterone level. Okay, so though they have similar metabolic pictures, okay, their clinical features are different. Okay, someone with Cushing's, what will prompt us to follow the Cushing's protocol is the clinical features. which someone with cons might not have. Okay, so that's one major difference. Okay, someone is saying we should look at the difference between the short and long synaptic. Okay, um, the long one is more effective, okay, than the short one. The long one, like the you are giving the person the synaptin for a very long time, so that one should produce effective how do you call it, cortisol production. But if you still give it for a very long time and then still the patient is not producing enough cortisol, then that one further diagnosed. Okay, so the long ones are more effective than the short one. Someone said, can you repeat the investigations for Conn? Okay, so for Conn's disease, um, before you even do an investigation, just do the normal laboratory. Okay, and remember that the laboratory, okay, even the examination, you see this patient has hypertension. Okay, and then the urine sample, when you take the urine for investigation, okay, they will tell you that no, there a lot of potassium in the urine, and the urine is more acidic. Then when you take the person's blood, the person has low levels of potassium, okay, and high levels of sodium. So hypernatremia, hypokalemia, metabolic alkalosis, okay, and hypertension. So these ones are normal things you do. Okay, but if you really want to diagnose it, what you have to do is to take the renin level. Okay, so measure the renin level and then measure the cortisol level. If the renin levels are high, cortisol levels are high, then it's not likely to be cons, because that means that the the increased renin is that which is producing the aldosterone. But if renin is low and aldosterone is high, then for that one we know that something else is producing the aldosterone, and this aldosterone, which has been increased, is giving negative feedback to the renin. Okay, good. So this is what you are going to do. You are going to do aldosterone renin ratio. If the aldosterone is more and the renin is low, then how do you call it? AC. Then notice that cons is likely. So you see, if it's more than 2,000, that means it's very high. The aldosterone renin activity ratio. That means you have high aldosterone with a little reduced renin level. Okay, so that one, the diagnosis is very, very possible. Okay, that one, established cause. Is it clear? Good. So I have explained all this. Good. There are some other tests that you do. Saline infusion test. Okay. Remember that high levels of sodium will inhibit aldosterone production. Okay. So if you give them the saline, we expect that you inhibit aldosterone secretion. If so, this will be inhibited in normal patients, but someone who has a tumor producing the aldosterone, whether you give them the high saline infusion or not, um, you are not likely to inhibit the aldosterone secretion. Okay, and there are some others, but I've mentioned the most important ones to you, which you must know. Good. The last part, the last session for today is this, what is called the congenital adrenal hyperplasia. Okay, for this one, as I said, take your time and look at this very, very, very well. Okay, look at this very well. For this, I will recommend Najib's video on the biosynthesis of the adrenal steroid. He simplifies it that you can really understand what is happening. So you can just get some 1 hour somewhere. I know you guys don't have time now. Okay, and then go by it. Okay, but I'll just simplify it for you. There are 3 hormones that you should know. 3 hormones. Okay, we have the 11 beta hydroxylase, 21 hydroxylase, and 17 alpha. So just keep these are the three hormones. If you know the three hormones, okay, you don't need to memorize a lot of stuff, okay. Now let me show you something. So these are the three hormones. So the three hormones are 21 hydroxylase deficiency, 17 and 11. So you just keep them in your mind. 20. So remember 21, 17 and 11. 21, 17 and 11. 21, 17 and 11, okay. And for the 20, okay, let's start with the 11. Now with all these, okay, there are two things we are looking at. We are looking at the ones that will present with hypertension, okay, whether they present with hypertension or not, and then whether they present with male conditions, okay, or male characteristics, okay, like hirsutism, that's increased hair, okay. So just remember these two things. The slides are a lot, but if you just remember, I'm just simplifying for you so you understand. Remember two things: hypertension or hirsutism, which is increase how do you call it, masculine features, okay, hair, excessive hair. Remember this. And I've given you three conditions. One of them is, or three deficiencies. One of them is 21, 17 and 11. There are three of them now, and I've given you two conditions. So there is one of the condition in which all these two are present. So there is one condition in which these two are present. Okay, that is one being hypertension and two being the hirsutism. They are all present. There's another condition in which only hirsutism is present, hypertension is not present. And there's another condition in which hypertension is present, hirsutism is not present. So there are three conditions, and these three conditions, this is how we distinguish between them. So once again, one of them has both hypertension and hirsutism. Another one has hirsutism, no hypertension. Then the other one has hypertension, no hirsutism. Okay. So the first one, let me start from the bottom. The 11. The 11 one has both of them. So 11 beta hydroxylase deficiency. It will lead to both both hypertension and then hirsutism. And I'll explain why. Good. Then when we take the 17, okay, when you take this the 17 the 17 one, okay, that one causes hypertension but no hirsutism or increased masculine features, okay. And when we take the 21, no hypertension but increased masculine features or hirsutism. So three of them, just three, okay. Let me simplify that one here for you. Okay, so we have the 11. Okay, let's follow this thing. Okay. Okay, so here I'll put 17. No, I'll put 11 here. Then I'll put 17 here. Okay, then I'll put 21 here. Okay. Then here I'll put hypertension. Okay. Then here I'll put the realization. Okay. Oh. Okay, over here. So let me see. So I'll use plus and minus. So for the 11 one, sorry. The 11 one, hypertension is present. This is present, okay. For the 17 one, hypertension is present. This is negative. 21, hypertension, negative. This is positive. So that's all. Once you remember this, You are done. Okay, let me see. Someone was asking something. Okay, okay. So um I think the level 300s have the slides. Okay, it's on the slide page. Okay, so now let's go back to the slide and see. Now let me try and go over this thing for us to see. So now you see, remember this, that the 17 one, if you remember the 17 one, okay. Sorry, let's start with the 11 one. You see, the 11 one, okay, or this enzyme over the 11 beta hydroxylase, okay, it works in the final process of producing cortisol, okay, as well as in the final process of producing aldosterone, okay. So that means that will lead to elevated 11-deoxycortisone levels, okay, and then that will also lead to excessive this hormone, okay, and this hormone, if this gets excess, okay, it will back up, okay, and then it will be shifted to the production of the male hormones, okay. So it's this male hormones which give rise to the virilization or the hirsutism, okay. But this hormone over these hormones, the 11-deoxycortisone and the 11-oxycortisone, okay, they also are like cortisol, so they can also increase the blood pressure. So that's why if I have deficiency of this enzyme, okay, if I have deficiency of this enzyme, I'll have elevated levels of this, which is 11-deoxycortisone, 11-deoxycortisone, okay, and this will back up, and then it will give me this, okay, and the androstenedione, okay, and this androstenedione is responsible for the male features, and this 11-deoxycortisone level is responsible for hypertension. That implies that if I have the 11 beta hydroxylase deficiency, I'll have both hypertension and then the virilization. Um yes, virilization. Okay, good. Let's start at the second enzyme. So the second enzyme is this 21 hydroxylase. So for that one, you realize that if this occurs, it's for production of progesterone to this. And I said the hormones over here are responsible for hypertension. So if you can't produce the 21 deoxycortisone and you only have progesterone, then there is no way you get hypertension. So that's why the 21 hydroxylase deficiency, there is no hypertension, but we have progesterone, and the progesterone is shifted to the aldosterone. I mean the androstenedione, okay, which gives them the virilization features. So someone with 21 hydroxylase deficiency will have only the virilization features without any hypertension because they are not producing any of these hormones that can give rise to hypertension, okay. And let's look at the 17 alpha hydroxylase, okay. So for that one, it inhibits conversion of the progesterone to the male hormones. Okay, so if I inhibit this, then all the progesterone will be used to produce the aldosterone. So for 17 alpha hydroxylase deficiency, remember that they will have hypertension, but they will not have this hormone because it's blocked over here. So that means I'm not going to get the male hormones, and then I'm going to get the progesterone over here is going to be used to produce aldosterone. So that's it. So I mean, I don't know if anyone can simplify this any further for you, but this is the best explanation you can get, okay? So that you don't memorize anything. Remember, 11, the 11 means the two of them are up. So 11, you get both hypertension and virilization features. 21, okay? 21, no hypertension, only virilization features. 17, hypertension, no virilization features. Great. Now let me see. I mean, it has been explained. So the 11 beta one, what's happening? There is virilization. There is hypertension. Full stop. That's all you should know. 17. I said for the 17 one, there is hypertension, no virilization. Okay. Okay, and then for the 21, no hypertension, virilization features. So the virilization features includes the ambiguous genitalis and all those things. Okay. Good. Let's end with the phaechrocytoma. So phaechrocytoma is also a secondary cause of hypertension, and this one we are looking at the hormones of the adrenal medulla. Remember, I said the adrenal medulla produces the epinephrine and then the norepinephrine, the dopamine, and all those neurotransmitters. So they cause tumor. One thing about this tumor is that these hormones are released in pulsatile. Okay, so their hypertension comes and goes. So it's like how do you call it? You measure the blood pressure in the moment, is okay. You measure it again, it's increased. You measure it, it's okay, it's increased. Okay, because the blood pressure is dependent on the pulsatile release of these the adrenal medulla hormones. Okay, good. It's also part of the men's disease. Okay, men's, if you remember from your pathology. Okay, men's multiple endocrine neoplasm, men's 2A and men's 2B, adrenal or endocrine pathology. So for this one, we just measure the catecholamine levels, adrenaline, noradrenaline, and then the metabolites of the catecholamine, okay, the methanephrines. And if you remember from nutrition and metabolism, amino acid metabolism, okay, we said if you have these, the vanillin mandelic acid, okay, it's a marker of increased catecholamine production. Okay, we'll end here. Any questions? Please, any questions?